Hello, everyone. And on the behalf of the American Heart Association, I'd like to welcome you to today's webinar, our national introduction to target aortic stenosis. My name is Gary Myers, and I am the Senior Program Manager with the American Heart Association's Target Aortic Stenosis Initiative. A few items today before we begin to let you know how to participate in today's event. If you'd like a copy of today's presentation, you can download a PDF version of it in the handouts section on your attendee control panel. If you have experienced technical difficulties, most user issues can be resolved by refreshing your browser. But if that doesn't work, please contact the GoToWebinar customer service team found in your confirmation reminder email that you all received. At the conclusion of today's presentation, you'll receive a link to access today's recordings, as well as an invitation to complete our feedback survey. We welcome you to submit text questions for your presenters at any time in the chat panel of the control panel. We will collect your questions and address them during the QA session at the end of today's presentation or in the chat box during as we are able. So let me please introduce the two speakers for today. Dr. Clyde Yancy is a Chief of Cardiology at Northwestern University Feinberg School of Medicine and an Associate Director of Bloom Cardiovascular Institute at Northwestern Memorial Hospital. He holds the Magerstadt Endowed Professor of Medical Chair and Professor of Medical Social Sciences. He currently serves as Vice Dean of Diversity and Inclusion, Northwestern University Feinberg School of Medicine. He is an honors graduate of Southern University, Baton Rouge, Alpha Phi Omega honors graduate of Tulane University of Medicine, and Beta Sigma honors graduate of the University of Texas at Dallas School of Business and Management. His research interests are in heart failure, clinical guideline generation, outcome sciences, and healthcare disparities. He has extensively published with well over 500 peer-reviewed publications and has been named among the top 1% of cited scientific authors. He is Deputy Editor of JAMA Cardiology, Senior Section Editor, Heart Failure, Journal of American College of Cardiology, and serves on the editorial boards for Circulation, Circulation Heart Failure, and the American Heart Journal, and the Journal of American College of Cardiology Heart Failure. He has served the NIH, NHLBI, PCORI, FDA, and AHRQ in a variety of service and leadership roles. He is a Master of the American College of Cardiology, a Fellow of the American Heart Association, a Master of the American College of Physicians, and a Fellow of the Heart Failure Society in America. He is a Chair of the ACC-AHA Heart Failure Guideline Writing Committee, Chair of the ACC Heart Failure Clinical Pathway Writing Committee, and Co-Chair of the Aortic Stenosis Advisory Group. He is former President of the American Heart Association, as well as a past recipient of the AHA National Physician of the Year and the Gold Heart Award. He is the recipient of innumerable Best Doctor and Best Teacher awards and has held a number of visiting professorships at leading academic medical centers. In 2016, he was elected to the National Academy of Medicine, one of the top most tiers of recognition for physicians. In 2018, he was named a member of the Minority Subcommittee on Health, the Department of Health and Human Services. Thank you, Dr. Yancy, for joining us today. Dr. J. Matthew Brennan is an interventional cardiologist at Duke University School of Medicine, specializing in the treatment of complex coronary artery disease and the clinical management of valvular heart disease. His research interests include shared decision-making, particularly as it relates to coronary and valvular heart disease, and the use of statistical techniques and study design to provide non-biased estimates and comparative effectiveness analysis using large randomized observational databases. Dr. Brennan has served as the director of the Duke Analysis Center for Transcatheter Valve Therapies, TVT Registry, and co-director of the Analysis Center for the Society of Thoracic Surgeons, STS database. He was the P1 of a U01 grant from the US FDA for the use of Medicare data for comparative effectiveness research and a PCORI award for comparison of TAVR versus SAVR using STS and TVT registry data. Dr. Brennan's research has most recently focused on defining the scale of undertreatment of aortic valve stenosis in the United States and bringing awareness to the issue. Thank you, Dr. Brennan, for joining us today as well. Dr. Yancy, I'll turn it over to you for opening comments.
Well, thank you very much, Mr. Meyer. It is really a delight to be with you today, you being all the persons in attendance, and sharing with you what we think is an exciting new initiative under the auspices of the American Heart Association with very generous support from industry partners. We really do believe that there are some great opportunities in the treatment of aortic stenosis and that we can use some of the tried and true methods that have been pioneered and perfected by the American Heart Association to close gaps in care, deliver equitable care, and substantially make a difference in a technology that can fundamentally change the natural history of a certain condition, aortic stenosis, but more importantly, can change the life and living circumstances of so many people in our country that are impacted by the heft of aortic stenosis. Dr. Brennan is going to be our first discussant. I'm delighted that I'm working with him today. He and I both have spent time in the Deep South, me at Tulane, he at the University of Mississippi, and we both have spent time in Chicago. I'm still in Chicago, but he was originally at the University of Chicago before heading to Duke. And of course, at Duke, he has interacted with so many of my friends and colleagues, and he is highly regarded by his peers, and I'm delighted that he's working with us and looking forward to his discussion, Gaps in the Journey of the Aortic Stenosis Patient Impact and, importantly, Implications. Matthew.
Thank you, Dr. Yancy, and thank you, Mr. Myers, for putting all of this together. And thank you to all of our participants for joining us in today's discussion, and to the American Heart Association for the opportunity to present on this topic. This is one that I've spent a lot of time in, and hopefully can help you to understand the picture and the landscape the way that I do, if I do my job correctly. So today I'll highlight gaps in the journey of the aortic stenosis patients, and I'd like to discuss the impact and the implications of those gaps specifically to both our healthcare systems and to our patients in particular. My contact information is listed below in this slide, and if anyone wants to reach out after this presentation and continue the discussion, I'm happy to talk with you further. I enjoy this topic and moving it forward. So these are my disclosures. Importantly, today's slides were created in collaboration with the team at Edwards Life Sciences and Boston Consulting Group, and they were reviewed by the AHA Scientific Oversight Committee. And today I want to accomplish three primary goals. The first one is to present the case for change in the care of our patients with severe aortic stenosis, and then to discuss the barriers to appropriate management in the pathway of those patients. And then finally, we'll look forward to opportunities to improve care. So let's get started with the case for change. Just a little background to bring everybody up to speed. Aortic valve stenosis is simply a pathologic calcification or hardening of the aortic valve, which is the last doorway or last stop on the way out of the heart. It is a progressive illness, and in its most severe forms, it occurs in somewhere between 5 and 10% of our older patients. As it progresses, the left ventricle, which is the pumping chamber of the heart, the muscle of the left ventricle thickens, it hypertrophies, and eventually fibroses, and it fails. And this failure, fibrosis and failure, leads to the classic triad of symptoms, including chest pain or angina, passing out or syncope, and breathlessness or heart failure symptoms. And once a patient develops symptoms, within 2 years, 1 out of every 2 patients with severe aortic stenosis will die if they don't undergo aortic valve replacement. So make no mistake, this is a progressive terminal illness that requires treatment. And by the time that we as clinicians recognize these symptoms of aortic stenosis, patients are often into that 2-year clock a fair ways. Now, aortic valve disease can be treated primarily through aortic valve replacement. In fact, that's the only effective treatment that's ever been shown to work for aortic valve disease. That can be achieved either through an open chest procedure or through a variety of minimally invasive valve replacement procedures, including transcatheter aortic valve replacement. An aortic valve replacement substantially attenuates the effect of this disease process. In fact, it places patients back on essentially an age-adjusted survival curve. The data shown here from the Partner 1 trial, these data have been replicated in multiple settings, including real-world settings, They show the impact of a transcatheter valve replacement as compared to what we would have called watchful waiting, or I guess still would call watchful waiting, which is really not effective. This impact has been shown across nearly every patient cohort that's been evaluated, and particularly in our older patient cohorts. But the benefit of valve replacement is not just for survival. The benefit of valve replacement is also for physical functioning and for social interactions. And importantly, these benefits translate to more time out of the hospital, reducing the cost of care and also improving the quality of life for these patients and their families. However, despite a poor prognosis of severe aortic stenosis and the proven benefits of even a minimally invasive procedure, less than 1 in 2 patients, less than 1 of every 2 patients with known severe aortic valve disease receives treatment within a year after symptom development. Now, this is the problem. So while undertreatment is observed across all patient groups, women and Black patients are the hardest hit. And although aortic stenosis would be expected to affect all patients equally, a woman is 36% less likely to be diagnosed with aortic stenosis than a man, and 20% less likely to be treated than a man. Likewise, Black patients are 65% less likely to be diagnosed than white patients, and 23% less likely to be treated than white patients. Now, interestingly, racial disparities in treatment have begun to narrow over the past decade with the more widespread availability of minimally invasive transcatheter therapies, but they still have not come back to equitable treatment rates. These data really beg the question, why? Why is it that we have so many missed opportunities both to save lives and relieve suffering? And so I'll spend the next several slides reviewing the highlights of what we know about the gaps in care. And I'm going to argue that there is no single silver bullet, that in most systems there are multiple opportunities for improvement at every step in the care pathway, from awareness to detection and diagnosis to referral and treatment. But a true fix to this problem really can only happen through a systematic approach to the care of these patients. So first, let's start with public awareness. As with any disease state, an informed populace will drive action. Breast cancer awareness is a prime example of this. When patients ask, healthcare systems and physicians respond. Unfortunately, public awareness for valvular heart disease remains abysmally low, despite a decade of TAVR-related literature, both in the medical and the lay press. Moving this needle is going to take a coordinated public awareness campaign, both nationally and within each of our individual communities. And low public awareness means that diagnosis and treatment of this disease process falls back squarely on the shoulders of the medical system. And as we know, there are holes throughout that system. For starters, our trainees and clinicians are not widely comfortable with the use of a stethoscope. And this is a problem. Here are data from 2 separate studies demonstrating poor accuracy of identification of aortic stenosis in graduating trainees, and still low accuracy among practicing clinicians. And this is not just a problem among primary care physicians. Now, you could argue that these skills are best given at the GME level. But among our colleagues in our referral bases, awareness to move forward with an echocardiogram for patients with unexplained murmurs is important. And perhaps just as important as a community is reframing this disease as a progressive terminal illness in need of routine surveillance, even in its mildest forms, with an average time from progression from mild to severe disease of roughly 5 to 8 years. So as the cardiac physical exam has been de-emphasized, we have necessarily, as a community, fallen back on echocardiography for diagnosis and surveillance, but the accuracy of the echocardiogram is only as good as the skill of the technician and the reader. And this is a challenge for healthcare systems, not just small, but also large systems. These are two studies that highlight this issue. The first, the left-hand panel, emphasizes the importance of getting multiple Doppler views for the appropriate grading of aortic valve stenosis severity, with nearly a quarter of severe cases missed if the standard apical window is the only one that's used for Doppler signals. The second emphasizes the importance of taking into account the full spectrum of echo criteria when deciding aortic stenosis severity, with a wide range in sensitivity on the individual metrics. And yet, in many echo labs, these are not standard. And as any clinician will tell you, the recognition of symptoms from our patients is an imperfect surrogate for left ventricular strain, although it is the primary driver of an indication for aortic valve replacement, with patients often minimizing symptoms in their clinical encounters. So, exercise stress testing and the use of biomarkers like proBNP have been adopted for further risk stratification of apparently asymptomatic patients with severe aortic disease. But these modalities are underused, with guideline recommended formal stress testing used in less than 10% of patients with severe aortic disease. Which brings us to the final step in the care pathway. Even among those for whom a diagnosis is made, referral and treatment rates remain suboptimal. Recent data show that the majority of patients with severe symptomatic aortic stenosis who are not treated have been referred to and evaluated by a cardiologist. Now, aortic valve replacement in these patients is a class 1 indication with proven benefits, and yet these patients are not making it past the point in the care pathway that should be best equipped to direct them. Why is that? A number of studies have shed light on this question. I'll highlight two here. In this study of roughly 350 untreated patients with severe symptomatic aortic stenosis, the investigators found that once a patient reached the cardiologist or the valve team, the primary reason given why patients were not treated ultimately was a refusal of care. Now, in a world of shared decision making, maybe you take a step back and you say, we're done. The problem is, a basic tenet of shared decision making involves the need for effective patient education. And patients have to first understand both the disease state, its implications, as well as the treatment options for them to apply their value systems. And when we dig deeper, we find ample reason to believe that patients, the communication is simply not effective for many of them, with data highlighting a lack of understanding and awareness by our patients and their families. Now, physician beliefs and communication styles influence treatment decisions and treatment discussions. We know that from our own clinical experience. This contributes to considerable variation in aortic valve treatment rates across cardiologists in the United States, such that the managing cardiologist is among the strongest determinants of whether a patient gets a treatment. And as you would expect, this variation affects patient outcomes. With patients who are cared for, a 22% increase in risk for patients who are cared for by cardiologists in the bottom quartile of treatment rates. Randomly, you walk into a cardiologist's office and your likelihood of death is 22% higher than had you walked in to the cardiologist's office down the hall. There's something wrong with that. And as if this problem wasn't complex enough, now we throw in a global pandemic with de facto calls for treatment rationing and deferral, which has led many in our field to ask a question about the flip side of this equation. What happens to those for whom treatments are deferred? Well, the answer is that the harm from delay is measurable. The study in the right-hand panel are data presented from a research letter that was published in JAMA last year. This is out of Switzerland. The investigators compared patients with less severe, but severe, aortic valve disease and aortic valve area between 0.6 and 1 centimeter squared, who had stable symptoms, who by policy, by national policy, their treatment was deferred, versus the outcomes with patients with more severe critical disease with unstable symptoms who were expedited to treatment. Now, naturally, you would expect that the patients with more severe disease would do worse. But what they found is that the patients who had deferral of their treatment had a 15% absolute increased risk of the rate of death, stroke, and unplanned rehospitalization by 1 month after that decision was made. Here again, the measurable cost of delay in treating these patients. These are data from Dr. Yancy's own hospital, from Northwestern Hospital in Chicago. Chris Malazery's group published this, showing that for every 5 weeks of treatment delay, there's an 8% reduction in the probability of survival. So once this diagnosis is made, as systems, we have to be ready to get these patients timely treatment. Now, over the past several minutes, I've tried to highlight the case for change and some of the many opportunities for intervention. In partnership with the American Heart Association, we as a professional community have an opportunity to reflect deeply within our own systems, to take stock of the opportunities for change, and to implement programs to improve care for our patients with valvular heart disease. We know that our system is broken, but it can be fixed. The American Heart Association efforts have led to improved treatment in heart failure, stroke, myocardial infarction care. No doubt, shining a light is the first step in finding the path forward. In just a few minutes, Dr. Yancy will highlight the exciting first steps that the American Heart Association's Target Aortic Stenosis Initiative will take to shine this light and walk the path to improvement as we continue to work together to build better healthcare future for our patients and for our communities. Why do we take these steps? Well, the answer to that is easy. We take these steps because our patients are worth it. Thank you for your time.
Thank you very much, Dr. Brennan. Appreciate that. That was a great insight into what we know now, leading into where we want to go. So again, thank you very much for joining us today. Dr. Yancy, any comments there?
So thank you. There are a couple of comments that I think are very important. I hope that everyone who is engaged with us today recognize the preceding graphic and understands what the aspiration is: goal level care. Understanding that by achieving goal level care, best possible performance, we can fundamentally change the lives of humans. I think that last graphic was spectacular. The older hand cradling the younger hand. We have to have respect for this generational legacy that exists in every family. And for that legacy to be intact, to be celebrated, we really have to provide best care for all members of the family. We saw the playful children. Now we see the older person, and we see that hand reaching out to the next generation. We want to enable that hand. A big part of who we are as American Heart Association is to really embrace the health span. How long can we achieve healthy lifestyles, healthy lifespans for the community? Yes, illnesses are inevitable, but can we compress those illnesses? That really is an overarching theme of who we are as the American Heart Association. We are relentlessly pursuing this ability to extend the health span. Now think about for a moment what Matthew shared with us. Dr. Brennan did a spectacular job of reflecting something that really is of historical importance. In a very short period of time, we being the scientific community, an absolutely fatal, untreatable disease, critical aortic stenosis in the high-risk person, and changed it into a manageable condition with the ability to extend life. That is a big pause moment. I must tell you, I've been an active cardiologist now for 31 years. In the first third of my career, unless those patients went to the operating room, there was simply no hope. And many of those patients that went to the operating room in the first and second third of my career, the challenges postoperatively were profound. In this last third of my career, I hope there's another bit of my career left, but in this current part, we can do so much more for so many more. And so I really applaud Dr. Brennan's articulation of this journey that we've been on, this journey in science, which is another big piece of who we are as American Heart Association. We endorse science because with science, we expose answers, and with answers, we can help people live and do better. The other thing that Dr. Brennan really developed for us is a challenge. We have a challenge with the diagnosis. We have a challenge with the recognition. We have a challenge with the implementation, and we have a unique, compelling challenge with the equity by which we deploy the most successful treatments for aortic stenosis. So all of those things taken together, taking best advantage of the science, understanding the awkwardness right now of ideal goal level care, the need for better implementation, and accepting the challenge to do this more equitably, working with our partners, we've developed Target Aortic Stenosis. I want to share with you the initiative.
Thank you, Dr. Yancy. You should have control of the slides.
Thank you. I have no relevant disclosures. Let me start with the initiative objectives. How will we get to this goal level care that I'm thinking about? How will we enable this vision of lowering cardiovascular mortality? How can we establish a new standard of care in structural heart disease? Pretty lofty goals. We'll get there the way we've done it before, and we've executed brilliantly on this many times over. First, we'll take a quality improvement approach. This has been tried and true. It's all predicated on a simple phenomenon, which is the Hawthorne effect. If we make data available to responsible teams, to physician leaders, to nurse directors, and say, these are your metrics right now. These are the standards by which we should all behave. There is a disconnect. What can you do with this? It has been remarkable to recognize how the organic process where someone sees their performance, recognizes the standard, and makes immediate real-time changes, sometimes even subliminal, to get there works. Second, we understand that this is still not a widely known treatment option. The public needs to be aware that sometimes when a grandparent is starting to slow down, starting to become forgetful, starting to have symptoms, it may not just be old age. I frankly don't know what old age is. I think what we have to help people appreciate is that there are biological conditions that are the underpinnings of these age-related changes, and we should make people aware of the whole portfolio of circumstances that may be responsible for this. And then partnerships. We've learned a long time ago that we can't go it alone. Things are more complicated today, things are more costly today, and there are too many stakeholders in the mix to not bring everyone into the mix that's got a relevant stake in this whole issue and deploy resources accordingly. So let's continue to explore exactly how we'll get there. What you see here now are parallel statements, important parallel statements. One is from one of our industry partners that very much articulates the intention to have a truly positive impact on people living with structural heart disease. The other, from the CEO of the American Heart Association, explicitly says we have a shared vision, that we are engaging in a partnership to effect change for all of the many millions of Americans that are impacted by structural heart disease. This whole initiative began just about 13 months ago. We've come far in our planning process, and I want to continue to share that with you. So what is the initiative? Increase awareness of the signs and symptoms, increase the percentage of those patients with aortic stenosis who are correctly identified and diagnosed, improve the clinical pathways and processes of care to enable better outcomes, and increase compliance with guidelines. So this initiative is beginning with these 4 very bold agenda items. If we execute on each of these, we will fundamentally change the health and living circumstances for those with structural heart disease. An important part of this, an important part of the leverage that the Heart Association has used in our quality improvement programs, has been to refer to a suite, SUITE, of guideline statements. These guideline statements, recall, are developed by teams, committees of persons deeply versed in the science, in the implementation, and the execution of the clinical trial, and the application of the data. As these teams come together, managing their relationships with the external community carefully, there are refereed statements that reflect the degree of alignment with the impact of a certain statement and reflect the degree of certainty based on the evidence that that statement is in fact true. So understand there's a dichotomy in the decision making. One is the conviction that the team has given a certain intervention and the extent to which that intervention will be helpful. The second is an assessment, not a conviction, an assessment of the supporting evidence that prevails. Sometimes the supporting evidence is just plain old common sense, and we call it consensus or expert opinion. But other times it is deeply embedded in well executed, large format clinical trials. So that's level of evidence A. Sometimes the recommendation is this is a must do. This is class 1. Nothing else matters. This is a must do. If it's a class 2, that's bifurcated into 2A or 2B with varying degrees of certainty. And if it's class 3, it basically is you should not do this either because it's not beneficial or because there's harm. Quite intuitive, very beneficial for the community to help understand how best to deploy these strategies. But look at these statements. For severe aortic stenosis, for asymptomatic patients with severe aortic stenosis and impaired cardiac performance, for severe aortic stenosis when undergoing other cardiac surgery, for asymptomatic severe aortic stenosis and low surgical risk, for symptoms of aortic stenosis, severe, in a peculiar format known as low flow, low gradient, typically women with smaller ventricles, and even for moderate aortic stenosis, undergoing other cardiac surgery. This really is a moment not for pause, but for applause. All of these statements were driven by relevant, well-conducted, randomized controlled trials. This is not a sophisticated guessing exercise. This is based on data which are adjudicated, as you see parenthetically, but data that nonetheless direct us on where we should go and how we should best treat patients that have structural heart disease. This really does enable our ability to establish a quality improvement program. Look at the participating pilot sites. I can tell you, I have personally been to each of these sites with 4 or 5 exceptions, and I can confidently tell you that there are leaders in each of these sites that are as committed to changing the natural history of structural heart disease as I am and as Dr. Brennan is. And we believe that this kind of quality initiative is a huge step in that direction. So how does this all come about? It almost seems as if I'm talking about sprinkling some magic dust in the equation. I'm not. It's a very calculated, very deliberate process. It starts by developing measures. What are we going to measure? What will the data be? How will we make that Hawthorne effect happen? What data will we put in front of teams and leaders to say, this is your performance, this is where it should be, this is the benchmark, this is where you are. Once we've developed those measures, then we deploy those measures as statements, as documents, as online resources, but it doesn't stop there. What we've learned over 15 years of quality improvement with the Heart Association, and I've been present for all 15 of those years, is that it takes renewed training, recalibrated awareness. So stakeholder training becomes incredibly important. The champions need to be reacquainted with the science, and then the sites themselves, the team members, the administrative group, they all need to participate in a training exercise that then allows us to deploy the measures in the pilot sites, 15 sites, make the measurements, and as the arrow subtly dictates, we then return back to the beginning and we look at the measures we've developed and decide if those measures have been helpful. I want you to pay attention to the arc that Dr. Brennan introduced earlier. I want you to recognize the continuous flow of that arc: awareness, detection, diagnosis, referral, treatment, and monitoring. It isn't just a pathway, it is an arc towards excellence because it allows us to target each component of the arc, identify how best to raise community awareness, how best to exercise the right diagnosis, the detection, the examination, the echo, how best to overcome barriers in workflow that prevent us from making these diagnoses. Think about that now listed group of physicians that's reluctant to refer. We have to understand what's embedded in that group. And then how do we make the referral an easier process? And how do we understand which patient requires which therapy with what level of conviction supported by what evidence? That's deploying the guidelines. And then it is continuously monitoring outcomes. And unlike where we've been before, we have the hard outcomes we've always had, that is death and hospitalization. But now we have very sophisticated tools to understand quality of life, specifically the Kansas City questionnaire, KCCQ. So this gives us a tool we've never had before because honestly, at a certain age, patients are most important in this. Am I going to feel better? It's always been a difficult thing to answer. It's been a subjective response. Well, do you feel better? Well, now we have a validated tool, particularly in structural heart disease studies, that says as you change your performance on the KCCQ questionnaire, guess what? You are feeling better. And so that gives us a target for this intervention. So how will this all take place? So we will develop these measures and embed these measures in the patient care pathway. Look at the measures that have already been considered for diagnosis. What's the percent of moderate aortic stenosis patients getting a follow-up echo? What's the percent of echocardiograms that hit a critical threshold for diagnosis? What is the percent of patients with this unusual representation? I call it a phenotype, where it's a small ventricle, low flow, low gradient, but still severe aortas. And what is it that we can do to better assess the number of asymptomatic patients with severe aortic stenosis? And are we able to document that in those asymptomatic patients with severe aortic stenosis, as Dr. Brennan introduced to you, are they going forward with a stress test? What about the referral? Here's another candidate measure. Can we identify the percent of patients diagnosed with severe aortic stenosis who actually going forward with a multidisciplinary heart valve team assessment within 14 days of the initial diagnosis? You saw the penalty of waiting. You saw that penalty. So this is a very important measure. What about treatment? This is the guts of it. Those patients who have a diagnosis of severe aortic stenosis, how many of them within 30 days have a definitive direction, either surgical aortic valve replacement, transcatheter aortic valve replacement, or palliative care if that in fact is appropriate? And then what's the ongoing monitoring? Well, we have three measures. We can look at the percent of patients who actually complete the quality of life questionnaire. We can look at the percent of patients who complete it at baseline and within 90 days after valve replacement. And then we can look at the percent of patients who had the critical 10-point delta change in the quality of life questionnaire consistent with deriving a benefit. And this would be measured at 30 days after TAVI. So we've got, I think, a suite of measures that when deployed will really help us change the workflow. This is part of this patient care pathway. Here is how measures are developed. There is a broad environmental scan, typically in the literature, looking at the relevant guidelines and the other published literature. And then we go through a process that ultimately gets us to number 4. This is where everything becomes critical. We have to define the denominator, those patients at risk, And then we have to define the numerator. What are we measuring? This really allows us to have valid measures that we can deploy broadly. Once we've gone through that process, you see this acronym SAG, S-A-G. That's the team, the advisor group that is overseeing how this all comes together. That team plays an incredibly important role because once it's approved by a team of individuals, professionals with content expertise, then we get into the development of the registry, then we get into implementation, and then we go beyond the pilot project and start to refine the measures, understand best practices in deployment. These are the members of the scientific advisory group. I'm speaking to you at present. One of my closest friends and colleagues, Greg Fonero, who is the acting chief at UCLA, is a key member. Suzanne Arnold is a champion. Dr. Arnold has been trained at the University of Missouri, Kansas City by the team that has developed the KCCQ questionnaire. Her research has been pivotal in helping us understand how best to deploy this questionnaire. John Spertus has been her mentor, and she has executed brilliantly. Wilson Setso is the chief of cardiovascular surgery at Penn Presbyterian Medical Center, and has been invaluable in helping us understand from the surgeon's lens how best to do this. Catherine Otto is one of the most brilliant imaging cardiologists in the country. She's at the University of Washington. She's a past president of the imaging societies in our country, contributes substantially to the imaging guidelines. Dr. Otto really has a very strong voice in how best to diagnose this condition. And then Dr. Pinak Shah, who is at Harvard, is really that guy in the cath lab that understands exactly what's involved in doing these transcatheter procedures. You then look at the suite of individuals we've brought together: imaging expertise, quality of life expertise, surgical expertise, cath lab expertise, and then heart failure expertise. And you begin to recognize that we've amassed a group that should be able to help us point this initiative exactly in the right direction. So let me end with this. I shared with you already, we've had a 15-year experience in the American Heart Association focusing on quality. In so doing, stroke outcomes are better, specifically because of Get With It guideline stroke. Acute MI coronary disease outcomes are better, specifically because of lessons learned from Get With It guidelines coronary artery disease and because of Mission Lifeline. Resuscitation outcomes are decidedly better because we measured how we resuscitate patients. We understand the demographics, epidemiology of sudden cardiac death, and you know what? Resuscitation outcomes are now better. And yes, the space that I represent, which is heart failure, because we've got 1.4 million patient records, and on an annual basis, we bring to bear about 15 publications. We have informed the community, and heart failure outcomes are again better. I submit to you then that this paradigm, this model that's evolved over 15 years and has been time and time again tested and shown to be effective, will once again prove to be effective in improving outcomes for structural heart disease. Greatly appreciate the opportunity to share with you this initiative. It's been a joy to work with Dr. Brennan to bring this information forward. I'll yield control of this program back to Mr. Myers. Thank you very much for your time and attention.
Thank you, Dr. Yancy. I'm going to skip ahead to a slide. Just want to make sure that we make the audience aware of an upcoming webinar that we'll have as well on the new guideline update, valvular guideline update. Dr. Brennan, anything to add or comment on for Dr. Yancy?
Yeah, I just want to say that was a terrific reflection and introduction of this effort, which is exciting. I hope the participants on this webinar can recognize the parallels between the pilot measures and the gaps in care that I highlighted. They're directly related, and this is an initiative that I think both our patients and our communities desperately need. So I'm excited to see this move forward. And I think there's a lot of good that can be done across our country and in our healthcare system by this initiative. So thank you.
Thank you, Dr. Brennan. So gentlemen, we have no questions. I'm going to give it just a second to see if any pop up from our audience, but if there are any questions, best to type them into the chat box, and we can pose them out loud to either Dr. Yancy or Dr. Brennan, or we can answer those in the chat box.
So Dr. Brennan, while we're waiting for questions, what kind of strategies do you think will work to better deploy TAVR for women with critical or severe aortic stenosis? Any ideas about what we can do differently for that very special group of patients?
Well, I think part of at least the early challenges in that patient population had to do with vasculature and size of your access point. So as the devices have gotten smaller, that I would expect, and as they continue to get smaller, that'll be better. But I think beyond the technology itself, as with any of these sort of categories of patients or groups, cohorts of patients who are being underserved, I think it's important to recognize that we need to figure out how to communicate to these patients better and to speak to the particular challenges of that patient cohort. So I think it's a public awareness piece is probably, if you want to target women, there's certainly terrific venues that you can use to speak directly to women, but also trying to speak to the things that are unique about our older women who are often caregivers themselves or for their families. I think there are ways through a public awareness campaign to try and reduce those discrepancies. So on the treatment side, I think it's a technology issue primarily, but then beyond that, I think it's communication as it is with other groups. I think we need to recognize, get out of this mold where we think that all communication is equal. So how you speak to one community necessarily needs to be different than how we speak to other communities. So people just respond differently and have different histories, different legacies, different priorities. So I think trying to understand that a little bit better in the female community is important.
So let me add to that, and thank you for your answer. What you didn't say, which I think is incredibly important, is that we have no evidence that the biology of aortic stenosis varies at all by gender, sex, by race or ethnicity. It's the same condition. It is this calcification of the aortic valve, trileaflet aortic stenosis, typically associated with the same risk factors that we talk about as the underpinning of cardiovascular disease. And so to believe that one group doesn't experience its natural history is a misrepresentation of the truth. The truth is that the biology is the same amongst all groups. So to highlight your point, we need to understand who are the decision makers. We need to understand how best to communicate with them. We need to understand what communication strategies work best in what environments and with what communities. I think that's how we can begin to think differently about this whole process, and where that becomes really germane in our target aortic stenosis initiative is that we have to rely on local answers to these problems. We can't rely on a national response. That's why teams are so important to help us understand what needs to be done in your center. It's been one of the really important assets we've evolved within the whole Get With The Guidelines family, is that we use the local teams, nurses in particular, to tell us what resonates, what works for their groups. So I think that's been a big part of this.
Yeah, I think that's right. Kevin Thomas at Duke, who's one of the outcomes investigators, has spent a lot of time looking at development of shared decision-making tools or decision aids in minority populations in particular, and has some really unique findings, I think, both from ICDs as well as left atrial appendage occlusion that would translate here. And so I think, we have shared decision-making tools or decision aids that can be applied and used in clinic. But I think one of the things that we need to be looking at, in addition to engaging our local communities, is having those educational pieces that speak actually to a community uniquely in place. And so that's something that as a national community that we can work on. I completely agree with you. It really is a local effort.
So that's a big part of the stakeholder training, right? Everyone believes they know the guidelines for valvular heart disease, but actually when we sit down and go over the detailed information, there's a lot of space that's covered that was not previously recognized. The same thing. Everyone nods their head when you say shared decision-making conversation, but the important attributes that qualify as a shared decision-making conversation have to be better promulgated. And you think about something like a quality of life questionnaire, there's almost a ho-hum statement. Oh, you're going to measure quality of life. That's a good thing. No, no, no. When you look at the specificity of the questionnaire and understand how carefully it's configured and how capably it allows us to really understand who's thriving and who's not, and it gives us an opportunity to overcome the subjectivity that's our own bias. Yes, well, I had the procedure. I think I'm okay. Or I don't really want the procedure, so I'm doing pretty well. No, when someone goes through the KCCQ questionnaire, we get to the truth pretty quickly. And so that's why the stakeholder training and the team indoctrination happens to be so important. Gary, are there any questions? Dr. Brennan and I could probably talk for a little bit longer, but we did want to highlight these important other issues of how we get to targeted communities, what it means to have this shared decision-making moment, and in particular, how this KCCQ model differs from just saying, how are you doing? Are there any other thoughts or questions that anyone wants to share with us?
Nothing in the chat box, but you both have shared your contact information as well as mine. So if anyone has any questions about the presentation today or about the Target Aortic Stenosis Initiative, they can contact any of us and we'll get them the answers. So thank you both for today's presentation. Any final thoughts before I give my wrap-up statement?
Yeah, I just want to thank everyone who not only has been in attendance today, but will listen to us in the future. I want to thank you for your attention. As someone who has seen the evolution of this science, this has been remarkable. And the best use of this science is to deploy it and deploy it correctly and broadly. We basically are deputizing all of you to make us a better vehicle for better health for our patients. And I'll go back to my opening statement. Who we are as American Heart Association is a group that is serving as a champion of the health span. And this is another way that we can restore health in those that have structural heart disease and enhance that health span. Dr. Brennan, I didn't want to usurp final words from you, but I just really wanted to speak on behalf of the Heart Association and say this is really important. What are your final words, Dr. Brennan?
I couldn't say it better. Thank you.
Well, thank you both. I really appreciate the time for today's both and for the audience, as Dr. Yancy pointed out. And I'd really like to thank Dr. Yancy and Dr. Brennan for taking the time to have this presentation today on our new initiative, Target Aortic Stenosis. For those of you attending after today's webinar, you will receive a follow-up email with a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback back. In that email, you will also receive a link to view a recording of today's presentation. So on behalf of the American Heart Association and our presenters, I thank you for joining us today. Have a great day. This concludes our presentation.